Pakistan, with a population of 180 million, is at the verge of population explosion. Pakistan lags behind its regional neighbors in many reproductive health and family planning indicators. After 67 years of independence, only 20% Pakistanis take benefits from public sector health facilities. 276 women die out of 100,000 while giving births. Only 41% of births are attended by skilled birth attendants. 74 children out of 1,000 live births die before their first birthday, and the contraceptive prevalence rate is only 35%. The government of Pakistan has taken several initiatives to address this situation, among which the lady health worker intervention has stood out as one of the most successful. Considering the low literacy among women folks, the Lady Health Worker program could reach to nearly 60% of the population, and even this varies from province to province, thus leaving the 40% highly marginalized population vulnerable to morbidity and mortality. In order to address this lacking, Hans conceived and implemented a model of working with low or no literate rural women to provide reproductive health and family planning services to their communities. These women were given the name of Marvi workers. Word Marvi is adopted from the name of a woman in folk story, is a symbol of dignity and women empowerment. The project was also named Marvi, Marginalized Areas Reproductive Health and Family Planning Viable Initiatives. The project focused on empowering local women, that is Marvi workers, and communities, that is women and their families, through capacity building to improve reproductive health and family planning outcomes with minimal dependence on external aid. The project was funded by the David and Lucille Packard Foundation with partnership of local community development organization Thardeep Rural Development Program and close collaboration of District Health and Population Welfare Department. The project was initiated in the year 2008 in the District Umarkot and is still operational. District Umarkot is the poorest district of the country located in southern region of Sindh province of Pakistan. It consists of barren tracts of sand dunes covered with thorny bushes. The population of the district is around 860,000 and 49% population of the district belongs to Hindu religion and 74% of them are low caste. Most of the population lives below the poverty line with literacy rate of only 6%. Nearly 50% of the total population is deprived of lady health worker services. The first phase of Marvi intervention started with conduction of baseline survey. The social mobilization strategy was designed and initiated with the formation of 350 community groups, each of men and women. In total 700. These community groups were trained and oriented on the project intervention and management. Since the project was targeted for 50% non-lady health worker areas of the district, therefore it was estimated that the same percentage of population needs to be covered. Thus, around 400,000 population was the target with an estimated number of 350 villages. From each village, one Marvi worker and a Dai were selected as per selection criteria with the recommendation of community groups, covering a population of 700 to 1,000, and hence 350 villages or cluster of villages were identified. The selected Marvi workers were trained through 12 trainings stretched on 60 days, which included classroom and community-based hands-on training session. The training and material was designed and adapted to train low or no literate community-based outreach health workers. The major topics covered were community participation, modern and natural methods of birth spacing, 3 delays model, identification of high-risk pregnant women, danger signs during antenatal, natal and postnatal period, post-abortion care. The Marvi workers were also trained on basic health products and later supplied with products like safe delivery kits, sanitary pads, modern contraceptives, oral rehydration, iodized salts, and some basic medicines from the list of essential drugs. Marvi workers later established Marvi House in her home. all the supplies to the Marvi workers were provided and replenished by hand social marketing program. Marvi workers were able to sell these health products and generate income from them. She was also trained to keep the records of her activities, supplies and sales through tally method. The trained Marvi worked in close coordination with her respective community groups in the village and had regular meetings with community groups to work out on different issues, including referral strategy of the village, which includes the list of identified volunteer blood donors, transport owners, identification of nearest referral health facilities, and skilled birth attendants. The village-based telecommunication wireless phone or cell phone and transport sources were made available or identified, and their name and contact numbers were displayed in Marvi houses. Along with the training of Marvi workers, 350 traditional birth attendants were also trained through a standard 10 days training program, one from each Marvi village. The training aimed to develop their skills on conduction of safe delivery and promotion of use of safe delivery kit. The trained traditional birth attendants worked along with the Marvis to establish and manage referral of complicated cases. The project Behavioral Change Communication Strategy was designed on the basis of Smart Chart communication technique, which addressed the need of Marvi and her clients. The health education materials were developed and provided, including pictorial posters, flip charts, and other material to conduct health education sessions in the community. The project was closely monitored through regular supervisory visits by hand senior and mid-level management team, monthly progress reviews, mid-term reviews, and annual reviews to maintain quality. District government officials from Health and Population Department also supported in supplies and supervision of project activities. Marvi project also supported 50 public sector health facilities through family planning and post-abortion care trainings and equipment for manual vacuum aspiration, thus making these facilities as women-friendly health facilities. Today, Marvi is not just an outreach community health worker but has emerged as a women leader for their communities. Marvi project has proved that in areas where there is no literate women to be trained as lady health worker, a low or no literate girl could be trained as community health worker. With the supervisory support of a lady health visitor, she has the potential to mobilize clients of reproductive health and family planning services with the support of community-based groups. The successful implementation of Marvi project has taken the Marvi worker out of the boundary of district Umarkot to 5 more districts, and their number has grown from 350 to 1,000. She is still awaited by millions of Pakistani women and children who do not have access to health facilities. Let us help to scale Marvi intervention in the areas where there is no lady health worker.